They go right here.
Okay.
We're discussing where our budget recommendations are going, and they're going right here, and they'll be culminated towards the end of the day. So we're pivoting to H266, which is around 340B, and we have Jen to do a walkthrough and several witnesses.
All right. Great. Good afternoon, Jen Kirby from the Office of Legislative Counsel. I put the language up on the screen. We are looking at H266, which is an act relating to protections for 340B covered entities and 340B contract pharmacies. We're talking about prescription drugs, and this would be a new subchapter in 18 VSA Chapter 91, which is on prescription drug cost containment. This adds a new subchapter on 340B drug pricing program. And you'll hear in more detail about what the program is, but briefly, it is a federal drug pricing program that allows certain types of facilities, certain types of hospitals, and specific other healthcare providers to use the federal program to purchase prescription drugs that allows them to acquire them at a lower price than they otherwise would be able to. So this is adding this new chapter. It starts with definitions as used in this subchapter. First, we have a definition of 340B contract pharmacy. That is a pharmacy that has a contract with a 340B covered entity to receive and dispense 340B drugs to the 340B covered entity's patients on the covered entity's behalf. And then we get to 340B covered entity, which is an entity that is participating or is authorized to participate in the federal 340B drug pricing program that is set forth in 42 USC, so the United States Code, section 256B. And the term 340B covered entity includes a 340B covered entity's pharmacy. So we have a 340B covered entity, which is a certain type of healthcare provider. They may have their own pharmacy, like a hospital may have its own pharmacy. Or it may contract with another pharmacy to receive and dispense the 340B drugs to the covered entity's patients on its behalf. That's kind of the universe of who we're talking about here. We have 340B drugs. A 340B drug is a drug that has been subject to any offer for reduced prices by a manufacturer under that federal law that creates the 340B drug pricing program and is purchased by a 340B covered entity. A discount is a reduction in the amount that a 340B covered entity is charged for a 340B drug at the time of purchase. Health insurer uses our regular definition, or one of our regular definitions, fairly broad definition of health insurer in Title 18 in Section 9402. Manufacturer has the same meaning when it's talking about prescription drug manufacturers or pharmaceutical manufacturers. So it uses a definition from the pharmacy licensing statutes in Title 26. Pharmacy means a place licensed by the Vermont Board of Pharmacy at which, and this is an existing definition that we're using again here, at which drugs, chemicals, medicines, prescriptions, and poisons are compounded, dispensed, or sold at retail. Pharmacy benefit manager has the same meaning as in section 3602 of this title, which is in the chapter on pharmacy benefit managers and licensure of PBMs, I call them, that was enacted in this committee last year, and this committee's done some work on it in the past. And finally, a rebate is a discount, and it's a type of discount, a discount in which the terms are fixed and are disclosed in writing to a 340B covered entity at the time of the initial purchase of the 340B drug to which the discount applies, but which the discount is not applied at the time of purchase. So think of sort of a traditional rebate. You don't get it at the time of purchase. You have to get it later. You'll see that come up in the bill. All right, so that was our definitions. Now we have discrimination against 340B entities prohibited. And this says that a manufacturer, so we're talking about a pharmaceutical manufacturer, its agent shall not deny, restrict, prohibit, or otherwise interfere with, directly or indirectly, the acquisition of a 340B drug by or delivery of a 340B drug to a 340B contract pharmacy on behalf of a 340B covered entity, unless receipt by the 340B contract entity is prohibited by the U.S. Department of Health and Human Services. So a drug manufacturer cannot in any way limit the ability of a 340B drug to be acquired by or delivered to a 340B contract pharmacy unless the federal government says it's prohibited. Next, a manufacturer or its agent shall not directly or indirectly require a 340B covered entity to submit any claims, utilization, encounter, purchase, or other data as a condition for allowing the acquisition of a 340B drug by or delivery of it to a 340B contract pharmacy, again, unless the claims or utilization data sharing is required by the U.S. Department of Health and Human Services. So in both of these, it's saying manufacturers don't get to limit the ability of a 340B contract pharmacy to participate in the 340B program. It's not up to the manufacturer. It's only restricted to the extent federal law says we have to, that the 340B contract pharmacies cannot be acquiring or delivering drugs. Manufacturer or its agent shall not interfere with the ability of a pharmacy contracted with a 340B covered entity to dispense 340B drugs to eligible patients of the 340B covered entity. Also, a manufacturer or its agent shall offer or otherwise make available 340B drug pricing to a 340B covered entity or 340B contract pharmacy in the form of a discount at the time of purchase, and shall not offer or otherwise make available 340B drug pricing in the form of a rebate. So that definition about rebate where the discount comes later says you can't do that. It says only discount at the time of purchase. It's not up to the covered entity or contract pharmacy to follow up later to get a rebate.
All right. Discount to the person buying the medication?
No, this is about the acquisition of the drug. This is between the manufacturer and the pharmacy or the covered entity. All right, then we get to reimbursement of 340B entities. With respect to reimbursement for a 340B covered entity or 340B contract pharmacy for 340B drugs, a health insurer, pharmacy benefit manager, or other third-party payer, or should say its agent. Look at this so many times and never thought. And it says is agent or its agent shall not do any of the following: reimburse a 340B covered entity or 340B contract pharmacy for a 340B drug at a rate lower than the rate paid for the same drug to pharmacies that are not 340B covered entities or 340B contract pharmacies, or provide lower reimbursement for a claim on the basis that the claim is for a 340B drug. So not disadvantaging a 340B covered entity or contract pharmacy.
Basically saying they have to reimburse the regular amount that they would reimburse regardless of how it was acquired.
So they can't reimburse less, right? So it could be more, but it can't be less than they would pay to a non-340B covered entity.
Yeah.
All right. Shall not impose, so that these are the payers now. Payers shall not impose any terms or conditions on any 340B covered entity or 340B contract pharmacy that differ from the terms or conditions applied to non-340B covered entities or non-340B contract pharmacies, including any of the following. So no terms or conditions that are on 340B that are different than non-340B, including they cannot impose fees, charges, clawbacks, or other adjustments or assessments, including placing any additional requirements, restrictions, or burdens on the 340B covered entity or 340B contract pharmacy that results in administrative costs or fees to the 340B covered entity or 340B contract pharmacy that are not placed on other entities, including affiliate pharmacies of the health insurer, pharmacy benefit manager, or other third-party payer. They cannot impose dispensing fees or pay dispensing fees that are less than the dispensing fees for non-340B covered entities or contract pharmacies. Cannot impose restrictions or requirements regarding participation in the standard or preferred pharmacy networks. Not impose requirements relating to the frequency or scope of audits of inventory management systems. Cannot impose requirements that a claim for a drug include any identification, billing modifier, attestation, or other indication that the drug is a 340B drug in order to be processed or submitted. unless that is required by the federal government, the Centers for Medicare and Medicaid Services, or the Vermont Agency of Human Services for administration of the Vermont Medicaid program. And they cannot impose any other restrictions, conditions, practices, or policies that are not imposed on non-340B entities. Also says they cannot require a 340B covered entity or a 340B contract pharmacy to reverse, resubmit, or clarify a claim after the initial adjudication unless those actions are in the normal course of pharmacy business and are not related to 340B drug pricing. They cannot discriminate against a 340B covered entity or contract pharmacy in a manner that prevents or interferes with any patient's choice to receive drugs from the 340B covered entity or 340B contract pharmacy, including for the administration of the drugs. And I will note there are a few sections, pieces in here that may look familiar because they were in the PBM bill from last year. So they are getting struck from there because they were in this specific context. So you'll see that coming up. So the non-discrimination with the patient's choice in subdivision B says, for purposes of this subdivision 4, it is considered a discriminatory practice that prevents or interferes with a patient's choice to receive drugs from a 340B covered entity or contract pharmacy if an insurer, pharmacy benefit manager, or other third-party payer places any additional requirements, restrictions, or unnecessary burdens on the 340B covered entity or contract pharmacy that result in administrative costs or fees to the covered entity or contract pharmacy, including requiring a claim for a drug to include any identification, billing modifier, attestation, or other indication that a drug is a 340B drug in order to be processed, submitted, or resubmitted, unless the indication is required by the Centers for Medicare and Medicaid Services or the Agency of Human Services for administration of the Vermont Medicaid program. Still on the payer prohibitions, payers cannot include any other provision in a contract between, we'll just say payer and 340B covered entity or contract pharmacy that discriminates against the 340B covered entity or contract pharmacy or interferes with a patient's choice to receive their drug from one of those, including the administration of the drug in person or through direct delivery, mail, or other form of shipment, or creation of a restriction or additional charge on a patient who chooses to receive drugs from a 340B covered entity or 340B contract pharmacy. So you can see this is all about sort of all the different angles at which there might be discouragement from an actor in using the 340B program. Cannot require or compel the 340B covered entity or contract pharmacy to submit ingredient costs or pricing data pertaining to 340B drugs to any health insurer, pharmacy benefit manager, or third-party payer. And finally, they cannot exclude any 340B covered entity or contract pharmacy from the payer's network on the basis that the covered entity or contract pharmacy dispenses 340B drugs or refuse to contract with a 340B covered entity or contract pharmacy for reasons other than those that apply equally to non-340B entities. Medicaid is unaffected. Nothing in the subchapter applies to Medicaid as payer. Violations. This allows a 340B covered entity, contract pharmacy, or other person injured by a manufacturer's, health insurers, pharmacy benefit managers, or other third-party payers or agents violation of this subchapter to bring an action in Superior Court. This is a private right of action for injunctive relief, compensatory and punitive damages, costs and reasonable attorney's fees, and other appropriate relief. And then it talks about what a violation is. A violation occurs each time a prohibited act is committed. So for purposes of section 4682, which is the section entitled Discrimination Against 340B Entities Prohibited, a prohibited act is defined as each package of 340B drugs that is subject to a discriminatory action by a manufacturer or its agent. And for purposes of section 4683, which is about what the reimbursement and the payers, a prohibited act is defined as each day that a health insurer, PBM, third-party payer, or agent engages in a discriminatory action toward a single covered entity. Finally, in the subchapter, it says nothing shall be construed to or applied to conflict with or be less restrictive than federal law for a person regulated by this subchapter. And then section 2 are those conforming changes I mentioned in the pharmacy benefit manager statutes. where it's just striking language that is now being added in this place instead because it was specific to 340B drugs and 340B covered entities. Although in the bill, we also talk about 340B contract pharmacies, which is broader than what's in the existing law. And the act would take effect on passage.
Any questions for Jen? Am I understanding that essentially what this does is it makes it so that manufacturers, payers cannot do anything to a 340B contract pharmacy or 340B provider that they would do differently for a non-340B?
Yes, and in addition, there are some provisions that are that don't apply in a non-340B context because of the pricing structure in the 340B program. And it's saying they can't sort of disincentivize or penalize or otherwise limit the ability of a 340B covered entity or contract pharmacy to participate.
So I'm just confused. It's a federal program.
It is.
So we have the right as a state to legislate.
We are doing some enforcement around it. So it is a federal program, but it affects entities regulated by the state as well.
So since we regulate those entities, we are allowed to, even though it's federal. I guess.
Well, we're not changing anything about the federal program. So we are recognizing the existence and the participation in the federal program, but we are not regulating the operation of the program itself. All of this is permissible under the program. But some enforcement, I think there are differences of opinion on enforcement. And so this is inserting the state in a more active enforcement role and giving a private right of action to participants to enforce their rights under the program.
So each state could have a whole different set of enforcement.
I mean, I think what we're really saying is what the language is saying is allow the entities that are permitted under the federal law to participate in the federal program to participate in the federal program. So states may have less strict methods of enforcing those protections, but I think there's less of a risk in this area of there being sort of a patchwork of different provisions than there might be. It would be, I think if the program were operating the way it is designed at the federal level and everyone was participating without creating disincentives, there would be no need for this legislation, but that's not, as I understand it, what is necessarily happening. I know there's been litigation over the issue of, over the existence of contract pharmacies and whether those are permissible under the 340B program. My understanding is that both the federal government and the courts have said, yes, that is a permissible way for states or for covered entities to implement the 340B program. But as there are lots of competing interests in healthcare, and this area is no different.
And other states have done things similar to that.
Yeah, some of this, and I think some of your witnesses may tell you more, but some states have done a lot. I believe a lot of this is or maybe all of this is modeled on some language that has been enacted or proposed in other states.
Any other questions?
Dr. Dennis, our witnesses, we've heard a lot about the problems in the 340B program, particularly FQFCs and that stuff. So we're going to hear from that too.
Yeah.
Okay.
Yeah, we're gonna hear from a lot of people, and frankly, the reason I put this on the agenda is because we keep having witnesses in here and we keep having this 340B dropped. And so we should figure out what it's all about. So that's why I asked Jen to do a walkthrough of this. Thank you. Thanks, Jen. So because we all now know exactly what a 340B program is.
We don't.
We don't. I said, let's start at the beginning and have somebody. So We have Colleen, and is it Myman?
Myman, yep.
Myman.
Yes, very good. Thank you. Most people don't get that.
So Colleen's
Okay.
virtual, I am in person. Little tag team.
Welcome, Colleen. So
I don't know if you can see
we're
me.
hoping to-
Okay.
we're hoping to get an education on 342.
I'll start for the record, Georgia Maharis, Bi-State Primary Care Association. Thank you very much for holding this hearing. And I'm my colleague, Colleen Myman, who's, I think, currently on the West Coast. But she is about the smartest person I know on 340B. And she has kept track of all the other states that are doing work in this area and is hopefully going to go through a little bit of why we're all talking about this really weird federal program. Because, you know, like 401ks, right? It's one of those things. So Colleen's going to start us off, and then I'm going to finish up with just a couple of additional Vermont specific things if that works for the committee.
Perfect.
Over to you, Colleen.
Great. Can you guys hear me all right? Everything
Yeah,
good on the
pretty
audio?
well.
Great. Okay. And hopefully you can see my slides and you got them a little bit in advance today, although not much. Before we get into 340B, I just wanted to make sure everyone has a basic understanding of federally qualified health centers. I work for the federally qualified health centers around the country doing policy issues. FQHCs, just in case you're not familiar with them, are the backbone of the nation's healthcare safety net. We are intentionally located in areas where there are a large number of medically underserved patients. Roughly 70% of our patients are below the poverty level, and we provide care to everyone who shows up, regardless of their ability to pay. And we are managed by governing boards that consist, the majority of which are patients of the actual health center. So we're small local groups managed by our own patients who turn nobody away. In Vermont, 1 out of 3 Vermonters actually get care at an FQHC, and there are 93 FQHC sites located in every county in the state. Okay. So please stop me anytime if you have any questions, or Georgia can weigh in as well, obviously. But I'm going to spend most of my time today giving some basic information on the program, because I've been doing federal policy for 30 years. And no program I have ever encountered is as complex and crazy as 340B. And it's very easy to get lost in and confused in the details. So we're going to start with the basics of the program, how it generates savings and what we do with them. And then I'm going to touch very lightly on the need for the different provisions in the bill in H266, but our speakers will go into that in more length. So, an overview of 340B. Well, it's got to be one of the worst names in federal program history. It actually refers to the section of the law that created it. It wasn't even, when they created this program, they didn't even give it a name. Okay, so it's section 340B of the Public Health Service Act. And what it does at a very high level, it says, okay, drug manufacturers, if you want to sell drugs to Medicaid and Medicare, then you need to offer discounts on those drugs to certain groups of safety net providers, and I'll define who they are. They include FQHCs. You need to offer them the discount on those drugs as a condition of getting to Medicare and Medicaid. So the key point to take away here is that 340B is funded through discounts provided by drug makers. It is not a taxpayer-funded program, other than the 28-person staff at HRSA who oversee the program right now. In terms of which providers qualify for 340B, about 85% of them are hospitals, DSH hospitals, but also critical access hospitals, sole community hospitals, public hospitals. DSH hospitals, disproportionate share being the lion's share of the program. And then there's this other group we call grantees, because they're groups that generally get some sort of federal grant for safety network. So FQHCs, Ryan White clinics, hemophilia clinics, family planning, STD, etc. If you ever hear the term covered entity, that is the official legal term for all of the providers that are eligible to participate in this program. I try not to use it because it's, not a very clear term, but covered entities means eligible 340B providers. So the next question is, how big is the discount? And I think if there's one thing to take away from here is that it is under drug makers' control to a large degree, how big that discount is. Okay. The statute says that there's a required discount. By the way, it's equal to the same discount that Medicaid gets. Medicaid gets it as a rebate on the back end. We traditionally have gotten it as a discount on the front end. But if it's a brand name drug, it's 23% off, 23.1% off the sticker price, so to speak. A generic drug is 13.1% off the sticker price.
I think we have a question,
But-
Colleen. Hold on one second.
Sure.
One question, Mari?
Hi, who gets to decide what the sticker price is? And can you give me more detail about the sticker price? Is that like
That's,
the acquisition,
I'm sorry.
the acquisition cost? Is that the retail cost?
it's the wholesale acquisition cost as collected by CMS in a mandatory survey that they do. The actual price of drugs, as you probably know, pharma's sticker, price for them is a well-guarded secret. And so CMS has to do a survey every quarter, I believe it is, but I'm not sure, to find out how much people are actually paying. And that's how they determine what we call WAC, wholesale acquisition cost. And then
Thank
the
you.
discounts come off of WAC. No problem. So there's a mandatory 23.1 or 13.1% discount. But back when this program was created in 1992, I should have mentioned this program's been around over 30 years. The same rule was put in this program was put in Medicaid. There was concern then about how quickly drug prices were rising. And so in an attempt to discourage drug makers from raising prices so quickly, they said, hey, if you raise prices, your sticker prices faster than inflation, we're going to make you give a bigger discount to 340B providers and to Medicaid. And the faster you raise prices above inflation, the bigger that discount is going to be. So in recent years, there have been a lot of drugs where the discount has come up to being almost the total price of the bill of the drug, not because that's what the statute required explicitly, but because the prices of the drugs have risen so fast. And I'm sure as lawmakers, you're very familiar with that. But it's important to note that the minimum discount, they're only required to do that 23.1%. Beyond that, manufacturers have control over the size of the discount. So two more questions about why was 340B created? Prior to its creation in 1992, many of the small safety net providers, like the community-run, community-based health centers, we had to pay the sticker price for drugs. At the same time, we had to make sure the services were available for our low-income patients. We couldn't afford to do it. Prior to 340B being created, there were maybe 10 health centers in the entire country who provided pharmaceutical services. The rest of them simply could not afford the losses they had to take to make drugs affordable. So 340B was created as a way to enable health centers and other safety net providers to be able to afford to provide pharmaceutical services and other services, which I will get to in a minute, by reducing how much we pay for it. Remember, a large hospital system or something can go out and negotiate discounts with the manufacturers. We don't have that type of market power. So when Congress created the program, they put in the report language that accompanied it their intent for the program. And they said the intent was, and I highlighted it here, to enable covered entities or 340B providers to stretch scarce federal resources as far as possible, reaching more eligible patients and providing more comprehensive services. So that's the explicit language from the 1992 congressional report. There's 2 points I want to highlight in that statement there. Number one, Congress in
I think we lost you, Drew. We lost your sound, Colleen. Colleen, are you?
I should just
Yes.
text it.
best serve our population.
Colleen?
Is there a question?
Well, we lost you for a minute or so,
On the first bullet of the two key points.
the first bullet.
Okay. No problem. Yeah, please let me know. It's an old hotel and the internet's a little funky here. The first point to note is that Congress intended the 340B program, the direct benefit, to go to the safety net providers, to the FQHCs, that means to the critical access hospitals, not immediately to the patients. Now, of course, the benefit eventually gets to the patients because the safety net providers are serving the underserved patients. So I don't want to suggest in any way that the 340B benefits are used by health centers to, I don't know, fund fancy vacations for their board or anything like that. But it's important to note that the benefit was intended originally to go to the safety net providers, not the patient. And I'll explain in a few slides later why that's important, that it's structured that way. It's also important to notice that 340B is about much more than pharmaceuticals. Yes, it enables health centers and other 340B providers to offer affordable access to pharmaceuticals. But by saving how much we were losing on drugs before, it frees up other funds that end up supporting many other types of services. So, oh, I forgot to take off my my highlighting here. Oh, maybe I'm using the wrong set. I am using the wrong set slide. Sorry.
Colleen, can I ask a question real quick?
Sure, absolutely.
Are there just certain categories of drugs that are eligible for 340B, or is it all drugs, or?
It is all drugs except vaccines, and no, that's the only real that's the only exception I know. So anything that they want to have covered under Medicaid and Medicare. If you don't want the drug covered under Medicaid and Medicare, you don't have to participate in 340B. But right now, it's pretty much everything. Okay. And if you give me a minute, I'm just going to pull up I'm sorry, I accidentally pulled up an old set of slides here. I'm very sorry about that.
Okay.
We'll find those in just a minute. But
While we wait, well, I think Leslie would like to make a
Well,
comment.
just a comment about vaccines, the state gives them out free, so it's not like people aren't gonna get them because they're excluded. They just want people to understand.
Mhm. Okay, sorry, I pulled up the wrong ones. Okay, let me scoot down here, enable editing. Apologize, you think you've got all your ducks in a row and there's always something you forget, right? Slideshow from current slide. Okay. So what I was talking about was about the fact that the program benefit was meant to go to the providers and it frees up funds for many services. And as you can see, that was directly with the program intent to provide more comprehensive services. In Vermont, the 340B savings, and I'll get into the mechanics in a minute of how these savings come about, they pay for a lot of services that otherwise are either unreimbursed or under-reimbursed. Things like dental care for the uninsured, mobile units, substance use and other types of mental health treatments, transportation services, etc. And I want to be real clear about something. As an FQHC, both by law and by regulation, and I'm happy to send links if anybody wants them, health centers are required to take every penny of our 340B savings and put them back into services that expand access for medically underserved patients. So just as I said, maybe the discount doesn't go directly to each individual patient, but the benefits go absolutely back to our overall population of underserved patients in whatever area our FQHC board feels is what is most needed in their particular community. You're probably thinking by this point that this is a pretty crazy way to fund a safety net. These drug discounts are what we're using to fund dental services and SUD services. And I have to admit, I think we would all agree with you. It is a crazy way to fund a safety net, but it is the way that has been in place now for 33 years. It is essential. 340B savings are essential to the financial stability of a lot of safety net providers, including FQHCs. In Vermont, those 340B savings account for 25% of net patient revenue. If 340B were to go away entirely, a lot of FQHCs would simply go out of business. And I will put my professional reputation on the line. That is not an overstatement. And I would also go so far as to say that I've heard from many critical access hospitals that the same is true for them. I'm far from an expert on critical access hospitals, but I hear that from them frequently. Finally, you're probably getting a little confused about where the money comes from here. So hopefully you have a handout of the chart. I'm going to go through the chart. This is just the top half of this flow chart. But this is trying to simplify 340B down. So let's start with box number 1 up top. Let's say you have a drug where the regular price, the wholesale acquisition cost is $100. And the 340B price is $70. So there's a $30 discount, maybe 23% because it was brand name and 7% because the price rate rose faster than inflation, right? Well, in the way the 340B program worked through 2020 and still works for many manufacturers, a health center could call up its distributor and say, okay, we need drugs sent, 340B price drugs, and you can send them if the health center is big enough to have its own in-house pharmacy, you can have them sent to the in-house pharmacy. They also will contract with outside pharmacies. It could be your Rite Aid, your CVS, your mom and pop, to make it easier for people to get to a place where they can get the drugs. Also, just to shorten the driving distance period. And also because if the health center can't afford to run its own pharmacy, their only option is to have a contract pharmacy. So the drugs get shipped to the health center owned pharmacy or the contract pharmacy. So let's start now going down the left column, okay? Let's say we sell that drug or we dispense it to an insured patient. That insured patient's insurance company pays us $100, us being the center, okay? We paid $70 for the drug. Insurance company paid us $100. We come ahead $30, right? Now, let's go back up and look on the right-hand column. Let's say that pharmacy, which could be contract or health center owned, sells the drug to an uninsured patient. Well, for a lot of our patients, $70 is not feasible. So let's say they qualify. I'm sorry?
No, we just had some coughing. It's a.
Okay, no
Keep
problem.
going.
Let's just say the patient qualifies for a sliding fee discount, and based on our analysis of their income, they're only, the cost is $20. So we sell that drug to them for $20. Now we're short $50. So what happens down here is, so on the one person, we're ahead $30. The other patient, we're behind $50. Let's say you sold that drug to 3 insured patients, the same drug. 3 insured patients, that's $30 each or $90 in savings. You take that $90, you take $50 of it, and you offset the shortfall to make the drug affordable for the uninsured patient. And you have $40 in savings left to fund other services based on what your patient board thinks is most valuable for your patient group. Any questions about that?
Mari?
I thought that the discounts were bigger than
It can be.
we have here.
Yeah,
you
they
give
can
me
be.
a-
And this is just trying to make the.
Can you give me a range?
Sure. They can range from, the only things that are required by law are the 23.1% off of wholesale acquisition by brand name, or the only thing that has to show up, and 13.1 for generic drugs. But let's take, for instance, the case of insulin, where we all know that the prices have been skyrocketing over recent years. Well, because those prices went up so much faster than inflation, that produced that additional discount, that inflationary discount, which was originally intended as to try to disincentivize drug makers from raising prices so quickly. clearly didn't quite have the intended effect. It's gotten to the point where you might have the price rose so fast that the discount on the insulin may far exceed the remaining. So it's 23.1%. So you've got 77% of the price left. The discount on due to the inflation of the price of the drug could exceed the 77%. In which case the price of the drug is actually negative according to the formula. In that case, 340B providers would be paying a penny for that drug, just enough to have it be enough that we could like officially document a sale. So the prices can vary all over the place. Like for instance, in the case of that insulin, a new policy went into place the beginning of 2023 that caused the prices of insulin to suddenly drop. You probably noticed prices of insulin dropped around the country in the beginning of 2023. That caused that inflationary part of the discount to go away. That took us back to only getting the 23 or 13% discount. So insulin in 2024 went from being a penny a vial or whatever it is, a stick or whatever, up to like 75 or different amounts depending on the particular drug. Does that make sense?
Yes, thank you.
Uh-huh.
Do we know,
Uh-huh.
do we know in the US, what percentage of drugs are purchased under the 340B program?
Yes.
I know the data exists. Yeah, go ahead.
I pulled it, Colleen. So in
Mhm.
2023, the entire 340B program was just over 66 billion. And that's around 7 to 9%, sorry for the range on that, of total drug costs. I wasn't able to get a firm, this is exactly the drug cost for 2023. So this range is 7 to 9% of total expenditure.
Okay, thank you.
So, okay. So that's it for the overall 340B, but I'm happy to go back if people would like to. The next piece I want to address was somebody asked about the states and states getting involved. Congress has been trying to address this issue for years without success. I have heard it that some of the lines they use on Capitol Hill are the first rule about 340B is don't talk about 340B because it's a morass, or, you know, Congress would rather find other electrical sockets to stick its fingers into. The bottom line is they just have not been able to address it. And I can pretty much guarantee you there's no way they're going to address it in the near future because major 340B reform does not produce savings. And we all know that that is the focus of the new Congress and the new administration. So this given that Congress has been unable to address this for now, they started really trying back in 2018. So what does that make, 7 or 8 years? The states have been stepping in. So here are a couple maps just to show you. There's 3 major provisions in this bill. One of them has to do with PBMs. All of these states here in blue have already passed laws around the PBMs. Okay. In fact, I think you had an old one that we're updating, but the good news, the point is over 30 states have already passed laws on this. There is nothing groundbreaking about any of this, other than as we've learned to make the laws more specific as PBMs have gotten more creative in some of the things they're doing, and I'll discuss that in a minute. On the contract pharmacy provisions, last year, about 22 states introduced bills. We now have 8 that have been enacted into law. This map is actually from the end of last year. A couple states have already moved it through one chamber. I know both of the Dakotas moved it through one chamber just this week. Kentucky has it through. So multiple states are stepping in as well. On the PBM piece, I am not aware of any lawsuits over the state laws. There have been multiple lawsuits over the contract pharmacy laws, but with one exception where the state honestly did not properly describe the program. these contract pharmacy laws have been upheld all the way up to the Supreme Court. So let me talk about what the three issues and potential fourth one here. The first one has to do with contract pharmacies. Okay. Starting in the summer of 2020, some pharma companies just said, you know what, we think these contract pharmacies shouldn't be allowed, and we're just going to stop shipping to them. Started with Eli Lilly. Their former head of U.S. operations was at the time the Secretary of HHS. So I think they probably knew they would get an okay reception. And they just said, you know what, we're going to limit you. Not if you have an in-house pharmacy. Well, it took a few steps, but basically if you have an in-house pharmacy, we're not going to ship any 340B drugs to contract pharmacies. That process has grown with more and more manufacturers piling on. We now have 37 drug makers that ban contract pharmacies for hospitals and 24 that do them for FQHCs. HHS has been trying to stop these actions. There have been so many court cases. One of them, we've been waiting over 2 years for a decision. So in the meantime, when nothing at the federal level is moving, the pharma companies have continued to add to and tighten their restrictions. Okay, that is meaning that, because they're the ones with the market power, I would contend here. That means that covered entities like health centers and critical access hospitals, we are losing out on those savings from the contract pharmacies. Okay, and those are the savings that underline our financial sustainability. Just as one example, I'm thinking of another rural state, not contiguous, but 75% of their health centers had to lay off staff last year because they have lost so much 340B savings due to contract pharmacy restrictions that they had to shut down specific services while they wait for a final decision on whether or not pharma can set these rules about contract pharmacies. Second point has to do with PBMs. In recent years, the PBMs have figured out basically that they can get the 340B savings away from the health centers and other 340B providers and use them to boost their own bottom line. There's a lot of ways to do this. I'm just going to give you one of the simplest examples, okay? Remember that sample drug I gave you where it was $100 was the regular price and we paid $30 for it? And we count on the savings we generate for our insured patients paying us the same as they would for any other patient with the same drug. The $100. Well, PBM started figuring out, oh, we can force you into a corner, health center, and you have to tell us which drugs are 340B. And then if it's 30B, we're going to pay you, in the case of one PBM, 30% less, just based on the fact that it was a 340B drug. Or we're going to force you to turn over what was the 340B price, which is actually illegal, so we can only pay you that. Bottom line is those savings that were meant to support the safety net have now gone into the bank account of the PBMs. And this is a relatively recent thing. They only discovered this loophole in the law maybe about 8-9 years ago. So that's the one that 30 states have acted on. Another piece addressed in this bill.
Can I interrupt?
Absolutely.
I have a question. So if the PBM is essentially taking that savings, is the PBM passing that savings on to the insurer, or are they keeping it?
I do not feel qualified to answer that question. I would say that their talking points indicate that they are passing it on to the client. But I know that if I were a client, I would want to see the actual paperwork to be sure of that. Typically, when they go into a state, they find one of the most popular employers in the state. I'm from Maryland. It was Under Armour. In Missouri, it was, Anheuser-Busch. And they say, we have to do this to lower prices for Anheuser-Busch, but they never prove that they're actually going to lower prices for Anheuser-Busch.
Leslie?
So I think it's, I would say you need to verify it for yourself.
Okay. Leslie, you have a question?
This may be for another person, I'm just not sure. How is it determined that the FQHC or that entity charges the patient?
FQHCs are required by law. It's one of the terms of getting our federal grant that anytime a patient gets, anytime a patient is below 200% of poverty, all the services have to be discounted for them. And also that's part of their mission as well as their, as well as the legal requirement. There have been concerns, particularly around some of the bigger dish hospitals, claiming that low-income patients are not necessarily seeing a discount when they go to the pharmacy. Not something I feel qualified to comment on, something we've been talking about a lot in terms of congressional reform. Sorry, I'm in a hotel room. I asked for a late checkout, but they might have forgotten about that. So, it's up, but this, like the specifics of how every health center structures a sliding fee scale are determined by its board, et cetera.
So what about not?
Does that answer the question?
Well, I'm interested in different populations, so how does one set of patients get charged one number and other people get charged other numbers? How does it?
Well, I can tell you in the health center case, it's entirely based on income. We can't just say like, well, you're this type of patient and 150% of poverty, so we give you this, but that type of patient, it's all based on income. But I would agree that one of the weaknesses of the current federal statute is that those rules don't extend to the hospitals. And so there's a lot more flexibility for them there to set those rules.
Yeah, it sounds like the pricing is inconsistent depending on income. Like if you make the same income as the next person, you may get a different charge. Is that possible?
So I'll take a slightly different angle. So a federally qualified health center has to have a sliding fee discount schedule that they offer for everyone under 200% of the federal poverty level. Their board has to approve that. And then that discount schedule is also approved by our federal regulator, HRSA. So it's not just the health center makes it up and go do, it's the federal regulator. And one of the things that the regulators look at, they do site visits every 3 years. One of the things they look really closely at is that sliding fee discount scale to make sure that it's being appropriately applied. Like they'll look at the policy, then they'll look at receipts, like they'll really cross-check to make sure people are getting it. Additionally, a health center does have the ability to implement other discounts for other purposes above that 200%. Again, it has to be approved by the federal regulator because that's how the federal regulator works. But there is an opportunity, and bottom line is it's community driven. So it's what that community board is deciding is appropriate for that with that federal oversight. Is that
The pricing, the board determines the price.
right? And then the federal regulator says, check, you did it right, or go fix it. And I've seen enough examples of go fix it. So I know that they're looking at it thoughtfully.
But did I hear you say that there's difference between the hospital application of the 340B as opposed to the FQHC? And you may not want to spend time on this, I totally get it.
So by statute, there are some differences between different types of covered entities. I would defer to our hospital colleagues on that as they are the experts on the hospital side. Colleen knows a lot generally about the program, but has a specific knowledge on the health center side. If that is okay.
Right. And I would say too that there's a difference between what is strictly required and what, just because something is not required doesn't mean they're not doing a certain activity. But still, the requirements that we are subject to come through our federal grant, and federal and hospitals do not get those federal grants.
Federal grant, didn't we hear something that it hasn't changed for 10 years and oh dear.
We're trying really hard on that front as well.
You're the problem.
Yeah. So, okay, I just had two last slides, and then you'll. One other point that this legislation is looking to address, and this is a relatively new issue, but multiple states are working on it this year, is manufacturers are now also moving to try to make the 340B discount a rebate. Right now, we get it as an upfront discount. You pay less upfront. But what they want to do is say, okay, you're going to have to buy all your drugs at full price, wait until you dispense one, then you have to submit all this data to us. And one of the manufacturers has put out all the information, has, I think it's 36 separate data fields they want for every individual prescription. Then the manufacturer will look at it, decide whether or not they think we qualify for a rebate. And then once we get enough rebates, they will finally send us a check or whatever the 2025 equivalent is of a check. Okay. The key points about that are that is a massive cash flow demand for us, but even more than the cash flow demand of fronting all those costs up front, and we figure it's going to be about 3 times 1 month's inventory on average, the administrative burden of having to pull together all of these pieces of data for every single prescription, and then track which ones we got denied, which ones they forgot, which ones we're fighting, is very, very concerning for us. And there's also the fact that it's the drug makers deciding if or when we get the rebate based on, like, one drug maker has put out stuff where they want all of the patients' diagnosis codes. And I guess they're going to say, well, we don't see a diagnosis. I'm just assuming, why else would they ask for this? Well, we don't see a diagnosis here of high blood pressure, so why should we give you a discount for a high blood pressure drug? Feels a little fox in the chicken coop, guarding the chicken coop to me. So this bill has language in there to prevent a rebate model from going into effect. It is not that we don't want to provide data. It is not that we do not want to be transparent. But this idea of making us front all of this cash and submit all of the data that they want and live on their timelines is very much a concern. To lead me to my final slide. Transparency is one of those words where it's really important to dig into what people mean by it, because it can mean a lot of different things. I want to be very clear that health centers are supportive of transparency initiatives. I've worked throughout the federal government. Health centers have the most extensive federal reporting requirements of any part of the healthcare system, okay? We absolutely are open to transparency initiatives as long as we are able to tell the full story. What we have a problem with is when people come in and just say, tell us how much your 340B savings is, with the implication of, oh, we're just going to take that. We want to be able to say, this is what we do with these savings. This is what will be lost to our communities and our state if you take these savings away. This is how much time and money we spend making sure we're compliant with this program. And we also want to be sure the data we provide isn't used against us, for instance, by a PBM being like, oh, thank you for telling us which drugs are 340B, so we now know which ones we can pay you less for. So I just want to be very clear. We are supportive of reporting requirements as long as they're in a way that allows us to tell our full story without undue burden. So I thank you very much for your time today. I know I've gone a little over time, so I apologize for that.
Thank you. Very informative, though. Yeah. Any questions? I have one, but if anyone else has. Mari?
Just to comment that, who gets to require reporting from whom? And I know you all know that I love PBMs. But I object to entities like PBMs and pharma dictating what or having a really heavy influence on what licensed independent providers in communication with their own patients, that they are practicing like medical providers. I really object to that.
I'm looking at, the various pieces of this. It's the rebates, it's the PBMs just essentially taking the savings, contract pharmacy bans. Right now, the current state in Vermont, what are we seeing all of these things happening? Are we more concerned of one over another? What are we seeing right now? And trends?
Yeah, I think what we're seeing right now is, thank you for passing the PBM bill last year and extending it permanently. So that's less of an issue in Vermont. We are definitely seeing the contract pharmacy bans. And I would offer that it's a real impact. Our health centers want their patients to go wherever they want to get their prescriptions, right? Wherever they want across the state. And the trending we've seen is that there's an increase in fees to such an extent and a limitation on the contract pharmacies, so much that they're losing kind of dollar over dollar revenue from the 340B program over time. So in 2024, they netted less money than in 2020, not even factoring in inflation. So real financial impacts. We have not yet seen rebate models being implemented in Vermont. That said, we've seen some activity that was, Colleen, correct me if I'm wrong, I think late summer, early fall, by a couple of manufacturers that HRSA's coincidentally also the 340B regulator, different part of HRSA, that they said, no, you can't do that. You can't do that rebate model. So it's out there and it's really only being kind of held back by guidance from HRSA. So that is, I think, a trend that we're anticipating coming into the fore. So all of it is needed.
Yep, and I think we have several of them, filing legal challenges about the rebate model, et cetera. So I would agree, contract pharmacies is the biggest, followed by the rebate model.
Do the FQHCs, do they report yearly or so, how much of their revenue comes from 340B?
So all covered entities report an awful lot of information to HRSA for being participants in the 340B program. It's actually right now, it's the 340B recertification window until March 20th. So everyone has to recertify over the next couple of weeks. So there's that formal reporting. On the FQHC side, the reporting that Colleen alluded to is this uniform data set that health centers have. I mean, it's like literally everything you would ever want to know about a health center. We boil it down into our Vermont source book, into content that is, at least I understand it because I can't look at the source data, like it makes my head spin. So that information is there. Unfortunately, right now that is down on the federal website as part of the federal websites being partially down. So I can't refer you to the federal resource there. So yes, that information is publicly available for health centers, and 340B revenue is considered patient revenue from a kind of like that financial perspective. So that's the series of tables where you would find it. In Vermont, as Colleen referenced, the 340B program is 25% of our health centers' net patient revenue, and that comes to around, I can use the paper, so I'm not misspeaking, I think it's approximately $46 million a year for the health centers.
Just for FQHCs?
Just for FQHCs. And I want to underscore Colleen's professional reputation around the financial fragility and risk you've heard about. Thank you. Our health centers would not be able to operate without this revenue coming in their doors. And yes, this is perhaps not how we would design funding the healthcare system in 2025 if we were starting fresh. But this is the system we have, and this is how the federal government said, hey, we think that the safety net needs resources. You guys over there make that happen. And so that's what we're trying to work around so that we can continue to provide services to Vermonters.
Is your percent of revenue generated from 340B going up or going down?
It is going down.
Where, so
the gross
is highest?
I think on a gross level last year, so 2020, we're always using a couple years on. So like the 2022 data would have the highest gross revenue, but on the net revenue side, so those additional fees and charges, it's eroding. So it's gone from in 2020, the fees as a percentage of revenue were 15%, and now they're 25%. The drugs as a percentage of revenue in 2020 were 14%. Now they're 26%. So real significant shifts in a very short period of time. and, kind of totally controlled by outside entities.
Thank you, both of you. And gonna move to Kevin Green.
Thank you.
Thank you. Get it from the hospital side. Hi, good afternoon. Kevin Green. Hi. Vermont Association of Hospitals and Health Systems. Great to see everyone and thank you for having me in. I think Colleen and Georgia provided a great background on the 340B program, so I'm not going to get into that. I do have posted on the website a sort of plain language outline of the bill to help you follow along with it. But I wanted to point out a couple things. One is, as Georgia mentioned, we are seeing a bunch of these restrictions taking place right now, and it is impacting the money that we're seeing from 340B. I know that Rutland Regional Medical Center, as these restrictions went into place, is losing $8 million every year. And 340B is a major affordability component in terms of our hospitals. If we don't have 340B, it will go towards the commercial rates. We know that Rutland Regional Medical Center alone in FY 2024 had to increase their commercial rate ask by 2% because of what was happening with 340B and the erosion there. And so we do think it makes more sense to protect the 340B program. Again, understanding no one likes this program. And in fact, with the talk of global budgets, I was really looking for a way of, can we get out of 340B? Can we have something where the hospital gets the global budget of what it has now and we're out of the 340B altogether, because we don't want to be in this game. But it does have a huge impact on us. And I think in terms of affordability, I think drug affordability is a conversation worth having. I don't think this is the vehicle for it, because what this is doing is ensuring that there is not discrimination by drug manufacturers, payers, and other folks for the 340B program. If we don't pass this bill, then the drug manufacturers benefit because they can keep discriminating around 340B, not pay out as much or not provide as much discount, and they will pocket that. I don't see drug manufacturers passing on the savings, and we haven't seen them passing on the savings from eroding the program. So again, happy to participate in a conversation around affordability. Drug prices are too high, and we can do that, but I don't think this is the vehicle for this. I think we need to protect it. The other piece that I want to point out is if we don't have 340B protections in place, we also lose the discount. We also lose the Medicare dollars as well, because this is not just a commercial insurance program. This is a Medicare program as well. And so we would lose out in that area. One last thing I want to speak to is the piece about the private right of action. So I know Jen sort of skimmed through that, but I want to address it directly, that there is a private right of action in this bill. We think it's different than wide private rights of actions because there are just a few sort of specialty areas such as FQHCs, Planned Parenthood, or hospitals that would be impacted by this. So it doesn't seem very widespread. And we know that the Attorney General's office is extremely burdened right now with everything that's happening on the federal level. And so we think leaving it as a private right of action will help ensure that this is implemented, but is not a burden on the Attorney General's office, and it's done sort of carefully and in a targeted way.
Do all 14 hospitals have their own pharmacies, their in-house pharmacies?
Leslie's shaking her head now at me.
Contracts, so.
I will check on that. I know, I was gonna say, if Grace Cottage does, I
But they
think.
have, but that's intentional,
Right.
and they're making a lot of money off, but now, then I can be thinking about that's backing off, and that's worrisome.
Right.
So I keep hearing about that, but I
Right.
don't believe Springfield has a.
Springfield may not,
Yeah.
some of our critical access hospitals may not, yeah, that's right.
Within your hospital budget reviews rate with Freedom Mountain Care Board, do you include in there income generated by 340B and how much you spend on services savings?
We have included information about 340B in the past. When the Green Mountain Care Board has asked detailed questions about it. And again, we are very open to providing reporting on 340B as long as it, as Colleen was saying, is not something that benefits the manufacturers or undermines the program, but, and isn't overly burdensome as well. But we are happy to look at reporting requirements.
In terms of the pharmacy in the hospital,
Mhm.
if a person goes in with a chronic disease, if they don't have a pharmacy, how do they treat that person?
You would just go
They have to
to,
have those drugs.
they would just go to a local pharmacy. And part of what this bill is protecting is the 340B discount flows through local pharmacies. And that's what the manufacturers are sort of targeting right now, are those local pharmacies.
Like it,
Well, and I don't want to make it, they're contracted pharmacies, so they can include bigger pharmacies, but also independent pharmacies.
I get that part of it.
Okay.
I'm just, somebody made the comment that do all hospitals have a pharmacy?
Yes, and now that I'm thinking back to it, I don't think every hospital, I think a lot of hospitals have pharmacies. I don't believe every hospital has a pharmacy.
There are, I don't know if you're talking about inpatients, but I think every
You know, I'm talking,
hospital has an inpatient pharmacy.
Yeah,
so
gotcha.
That's how they get their medications
Yeah.
inpatient,
Yeah,
but
yeah.
the outpatient pharmacies are different.
Yes, every hospital can disperse medication while someone's in the hospital. But if they're going home, yeah.
Where does the patient payment come into all of this and their savings?
Yeah, so the program was set up to ensure that providers could treat patients, reach patients. It was not a pass-through for the discounts. That being said, UVM Medical Center has a health assistance policy where they provide free or discounted prescription drugs to low and middle income Vermonters. And so there are hospitals that use it specifically for providing prescription drug discounts, or other hospitals that use it for SUD treatments. It can be used in a variety of ways.
The 340B program was not set up with discounts.
It was not set up in mind with discounts to patients. No, it was there to stretch scarce federal dollars for
Right.
safety net healthcare providers.
And then if they make profit from it in any way, it goes back into their services or operations.
Yes.
Got it.
Yes, for instance, for the community health centers, that's in law and in our operating regulations. It's considered what we call program income. And program income must be reinvested into the purposes for which you got your grant in the first place, which is expanding access for underserved populations.
do we have any, is that federal policy?
Federal policy
Where
for,
the investment, where the proceeds must be reinvested, how they must be reinvested.
It's federal policy that applies to the grantee types of 340B providers, but I'm not aware of it applying to the hospitals.
correct.
Most of the hospital groups I've spoken to are very comfortable with it being added. It just wasn't, it actually comes from a different part of the law, not the Section 340B law. So that's where the question came from, or that's why it only applies to some.
Do you want to, oh, sorry.
Oh, no, I was wondering, is there a trend at all on what contract pharmacies are being eliminated and which ones aren't?
So the way we've been seeing it is this 40-mile rule. Pick a one contract pharmacy within 40 miles of your hospital, and you can't contract with any other pharmacies. But I haven't thought to look at in terms of, do you mean like a CVS versus a local pharmacy or anything like that?
Yeah.
I'm not sure about that.
Is it, Mari, what vertical integration of?
No.
Any more questions for Devin?
Thank you.
Thank you.
Thanks.
Hi, Kelly. Kelly Ryan, that's
Hello, excuse me, how's everybody?
good.
Thank you
Thanks for joining us.
I'm sorry I couldn't be there in person. I'm just across the border in Albany, and I really never like to turn down an excuse to come to Vermont. I just could not make it happen today. So I appreciate you letting me zoom in, and I know we're running a little bit behind, so I'm going to try to go quickly. You have also going to share while I'm talking so you can see my deck. You have our deck, you have our detailed statement, and some of the background has already been covered really well by folks in the program. The folks that have testified previously are doing two things at once, which is never safe. So I will just kind of jump right in, and I've tried to take some good notes while you all are asking questions, and to the extent I can circle back on any of those in my presentation, I will do so, and then obviously happy to take more as we go along. This has already been covered really well. Just a quick overview of the history of the program. I know there are some questions about the scope of discounts. So the average discount in the 340B program, and it was explained well how it varies, from drug to drug and across the board, but the average discount is 57% below the list price. Most of the rest of this has already been covered, so I am going to just kind of keep trucking along. Maybe. Okay, so here is the scope of the program as it stands now, right? So, as we talked about earlier today, 340B was conceived as a safety net program to help certain providers. It really came out of the creation of the Medicaid drug rebate program because manufacturers were providing discounted medicines to FQHCs, to these safety net providers prior to the MDRP. But then the way the best price rules worked, it created some, can we do that and not follow best price? And so very quickly after, that was an unintended consequence. No one meant to curtail those discounts with the Medicaid drug rebate rule. So 340B came very close afterwards. Just to give you a little scope of the program, I went back and looked, the furthest back number I have just for the scope of the program in 2012, it was $6.9 billion. So now it's up to $66 billion. We'll talk a little bit about why that's happening. But what we are seeing is regularly 20+% year-over-year increases. That is happening. And we talked a little bit about some of the guardrails that manufacturers have tried to put on the program. That 20+% increase is happening even with with that, right? So the idea of a bill like this, which would enshrine this concept of unlimited access to any number of contract pharmacies, that would expand that growth even further. Let me just go. So this is a helpful slide and it is simplified, but just to kind of give you a sense of how the dollars flow. And I know there have been some questions about this, right? The hospital could be an FQHC. It's just, for graphic simplicity, it's a hospital in this example. But as you've heard earlier today, right, the manufacturer provides a discounted medicine either to the facility itself or, as we've been discussing, to contract pharmacies. And the patient has to be a patient of that provider. And then the patient goes, this is all outpatient drugs. So then the patient goes to a pharmacy and, patient has no visibility into the fact that he or she is a 340B patient, right? 340B, as we've talked about, is attached to the provider, to the facility, not to the patient, right? So, it is not a means-based program like Medicaid. Patients typically have no idea that they're a 340B patient. So that could be your uninsured neighbor down the road. That could be Jeff Bezos. Like that person, all of those people are a 340B patient if they walk into a 340B facility. And like I said, the average is about 50%. So that's including, and then this is how over here on the right, kind of in a very simple example, how the profit is generated. And this is, similar to other flows that you've already seen today. So let me go one more. Okay, so we've been talking about contract pharmacies, and I just really want to dive into that a little bit because that is a key part of this bill. This bill would lock in this concept of unlimited contract pharmacies. And it's important to understand that the term contract pharmacy does not exist in the federal law. It does not exist in the regulations implementing 340B. It is entirely a sub-regulatory construct of HRSA. And the way it came about, I think we've touched on this a little bit, right? When the program was created, the savings do flow through a pharmacy. And so if you are, an FQHC and you don't have an on-site pharmacy, the intent of Congress was for those clinics to be able to participate in the program, but if they don't have a pharmacy, they can't participate in the program, right? So HRSA pretty quickly realized, we need to figure something out to make sure that the folks we want participating are benefiting. And so early in the program, HRSA said, okay, you can have one contract pharmacy. And then they adjusted at some point and they said you can have, 2 or 5. It was sort of incremental. And then in 2010, they changed their guidance. Again, this is all guidance. It is not described in law, and said you can have an unlimited number, right? So what House 266 would do, it would take this guidance and lock it into state law. So federal sub-regulatory guidance now becomes state statute, which raises some concerns. But what really is problematic is this huge growth. And you've heard a little bit, we were talking about, the impact on participants in the program. And I heard a couple of mentions of the FQHCs are losing revenue because they're paying fees. And I'll get to this a little bit later. There's a slide at the very end that, the state of Minnesota has done the first real sort of deep dive report. And they looked at this issue, right? So they asked providers to say, where's your revenue coming? What are you losing? And these third-party administrator, middlemen, consultants, folks that are very often vertically integrated with PBMs and the large chain pharmacies that are also vertically integrated with the PBM, everyone's related. Minnesota found that 16 out of every $100 in gross 340B revenue is going to these 340B programs, and up to 10% of grantees actually have negative 340B revenue as a result of these fees. What this bill would do, that's obviously concerning. What this bill would do is lock in all of these contract pharmacy relationships that are integrated into this program that is causing that problem. So I just wanted to, heard bits and pieces of that over the course of the testimony, and I just wanted to make that connection. There are real problems with the program. I think what we can all agree, I've heard a couple times today, right? The program is not what we would construct if we had a magic wand to start today. It is very broken, and we just want to express some real concern about taking some of the most broken pieces of the program, some that are diverting resources away from exactly the kind of providers that this program is designed to help and support, and send it off to third-party administrators, to for-profit chain pharmacies vertically integrated with PBMs, and we're seeing an awful lot of that happening. And so this sort of fleshes that out a little bit. And we talk about who are the contract pharmacies. By and large, they are the big guys, and they are the big guys that are vertically integrated, right? So, you know, more than half of profits that are retained by contract pharmacies are concentrated in these 4 companies. Many of these companies are also vertically integrated. And then on top of it, many of these companies are vertically integrated with these third-party administrator sort of 340B benefit consultants. So this is just a little snapshot of the reality of the program. One of the other things that has come up quite a bit that I wanted to dive into a little bit is the idea that 340B doesn't cost anybody anything, right? It's just manufacturer money that goes to providers that need it, and that's great, and everybody wins. But the data don't show that. So there has been a bunch of research, especially over the last couple of years, as the program is growing, folks are starting to notice, like, hey, this is actually having an impact. So IQVIA did a study, and they looked at just one piece of how 340B is driving costs across the system. And that piece is the fact that commercial payers, whether it is, you know, private employers, or frankly, whether it is a state government employer, are losing rebates because the discount is getting gobbled up sort of earlier in the process. 340B gets it. You get that 57% discount on the front of the process, and then the commercial payers aren't able to use that claim for their rebate numbers, and so they end up paying the full price. And this has a very real cost. Pardon me. So IQVIA looked at this across the states. They looked at kind of the big picture number, and they identified, $6.6 billion of increased costs because of foregone rebates in the employer market. And then they separately looked at state and local government plans and found about $1 billion there. And they did do a very wonky deep dive on a state-by-state analysis. We will provide you this document. And so the conservative estimate for Vermont is Vermont employers it costs Vermont employers over $17 million in foregone rebates, and local government employers about $3 million. So just again, to sort of lean into the idea that this is not just a gift in the system and that it doesn't have costs, because it truly does. There was another report that took this another sort of step, a little bit more abstract, but Magnolia took a look at, okay, if there is all this increased spending in the commercial market because of the 340B program, and employers are spending more on healthcare because of this, if they had, and health benefits, of course, are not taxable. And so if they had used that money for wages instead, which are taxable, is there a loss there? And so they found about $1.8 billion in lost federal and state tax revenue. Again, that's a little bit more of an esoteric hypothetical analysis as compared to the lost rebates, but I just did want to flag that that is recent research that is out there. So we pulled some of this into a fact sheet, have this, our graphics for some reason don't have all the citations, but I do have them, and I will make sure that Laura has it so you know where we get all of these numbers from. There are sites to all of the papers. I've already talked about the Vermont specific numbers, but this just gives you a little bit of a sense of the scope of the program in Vermont, and really the fact that there are tangible costs to Vermont employers, to the state as an employer, and therefore to the system in general. Before I leave that foregone rebate point, just one other thing I wanted to flag. The state of Utah did a fiscal note, these bills are being considered in a number of states. That's absolutely true. We've seen variation in how states assess fiscal impact, but Utah did a fiscal note on their 340B contract mandate bill that walks through basically the same analysis I just explained on, with respect to foregone rebates as it would relate to state employee health plans. It's actually very well done. It is very simple. They just kind of lay out the numbers step by step. So that's a public document, and I'm happy to share that if that's a little bit easier to digest than the very wonky IQVIA paper. But states are recognizing that these bills do have a fiscal impact. And states are also looking at, from other directions at how 340B is impacting them. So the state of North Carolina treasurer took a look and very sort of narrow approach, right? They looked only at oncology drugs as it applied to the state teachers' healthcare benefit. And they found that 340B hospitals billed state employees an average markup of 5.4 times for cancer medicines. Oncology drugs are a big chunk of 340B, so that's driving a lot of spending. And they generated an average of nearly $14,000 in profit per claim. And so the North Carolina treasurer very clearly identified that, and the report also goes through comparing 340B hospitals to non-340B hospitals to see if there was a difference, and they identified that there was. So that is another sort of public independent source that walks through some of these concerns about costs to states, especially in the context of states as employers, that I think is worth considering and at least giving some pause to understand the impact of this exponential growth in the 340B program.
Can I just,
Yeah, absolutely.
because I keep thinking this thought as you're going through your slides. In your last slide, they're charging a markup of 5.4 times for cancer medications. Or that they generated 13,000 change in profits per claim. But if they're getting a huge discount, they're being reimbursed. Aren't they being reimbursed at the average reimbursement? Doesn't that just imply that, frankly, cancer drugs are way too expensive?
They are, so we see markup of medication, especially, I apologize for the scratchy throat today. Just even outside of the 340B program, there is a ton of data showing the markup of medicines, even over list price or over negotiated price, to commercial commercial payers and their reimbursement. So that's the negotiated rate between the insurer and the hospital. And that's what's going on there. So the 340B hospitals are getting, in North Carolina, are getting, let's just say it's that 57% discount. And then, so their acquisition cost is already very low. And then they are marking up multiple times over and charging the state plan or commercial insurers that much higher number. So expanding their gap for the profit generation. And that is, another sort of cost driver that I did not really dive into in these slides, but there are data that show that 340B providers prescribe more and more expensive medicines than their non-340B counterparts, and some of that absolutely can be acuity patient, right? There are plenty of reasons. I don't want to at all imply that it is just because of 340B, but there is growing evidence that this program is just driving drug spending in general because of this incentive to expand the gap between what you're getting reimbursed and the acquisition cost of the drug.
Just seems like that's more of a contracting list price problem than a 340B problem. But Lori, did you have a question?
Yes, Kelly, thank you. So, and I apologize if I missed this at the beginning of your presentation. So you've laid out all these costs, and I appreciate you adding in some of the Vermont data, because I was going to ask for that. But where does pharma play in all of this? And so I understand you're advocating against the bill because of the potential cost increases that you've laid out, but where does pharma play in this?
So we are the trade association for the brand manufacturers. Sorry. So our interest is this program is completely off the rails. It is so far beyond what it was designed to do. We are seeing more and more evidence that it is not helping the folks that it was supposed to. Exactly, for an example of 16 out of $100 are going to middlemen consultants, not to patients or to the FQHCs or the hospitals that are serving those patients, right? So we, from a policy perspective, have real concerns with the growth of the program. We absolutely think the program needs some reform. I would agree with previous speakers that, I think we may all be banging our head against the wall trying to get anything to happen in DC right now, but from my perspective, ideally, that is where this happens so that you don't have a patchwork, that you really fix the program. I think that really fixing the program, like not everyone's going to be happy, right? Like all the players are going to lose a little bit, but you get the program back on track. Where we really have concern with state bills like 266 is taking some of the most problematic pieces of what is happening in the program right now that don't even exist in federal law and locking that into state law is just going to keep perpetuating the problems that we're trying to push for meaningful reform.
I would say nothing is ever locked in state law because we can change our laws. So how does the manufacturers benefit from this? How do you benefit from 340B or don't benefit from 340B?
I mean,
Yeah, you first, about manufacturers.
Yeah, so I think probably what you're getting at, right? Their manufacturer dollars in play. Absolutely. Yeah, that is the case. I will say that the growth in this program is driving drug spending across the board for all of these reasons we talk about. And I, come and talk to you all a lot and get a lot of questions about drug spending. And a lot of it is driven by programs like this and not actually by manufacturers, right? 50% of spending on brand name drugs goes to someone else in the supply chain other than the companies that researched, developed, took the risk and manufactured the medicines, right? And I know that we've talked about this a lot in the PBM context. So we have an interest in making sure that this program gets back on track, serves the folks it has, and, maybe we get less blame for things that are beyond our control when folks are marking up medicines, 5+ times, and then the conversation is about drug spending. Drug spending is much more than, the price of a drug, and we know that the net price of drugs has been at or below the growth has been at or below the rate of inflation for a number of years.
Okay, thanks.
Okay. She answered my question. Okay.
So I'll just do one last quick slide. Just mentioned this earlier, but I do think it's really important, and I would really encourage the committee to take a look at the Minnesota report or the executive summary, because it was eye-opening how this program especially is impacting grantees, right? And when we're talking about making sure that a program designed to help safety net providers is starting to not do that, it's a problem. And so Minnesota, like I said, is the first state to issue a report like this. This first report, the statute that generated it, did not include physician administered drugs. So and the report identifies this is very much a conservative estimate. So they went back and they changed the statute. Future reports will take that broader picture of the program. And like I mentioned earlier, oncology drugs are a big part of this. A good chunk of those would not have been included in this Minnesota report. So I would not be surprised to see future iterations have, some of these numbers that, TPAs and other external parties are receiving 16 out of every $100, that we know grantees are paying more and more fees to these TPAs and sometimes having, net negative revenue in the 340B program. I wouldn't be surprised when we get more complete data in the out years that starts to look even worse. And it's, it's a concerning report, and I think it will give you all a real vision into sort of the scope of the program, where the dollars are flowing. Is it really helping who's intended to help, and how do we right size it? And I will stop there and take questions.
Stacy has.
Hi, Kelly. Thank you so much for your testimony. It was very informative. Do you represent Eli Lilly?
They are a member of our association. Yes, I do not represent them personally.
But they're a member of Pharma.
Yeah.
I was reviewing a letter that they sent the committee, and they said several things in it that I found very interesting. One, though, that I would really like to ask you is to speak to their point that we should focus on reforms that benefit patients and not big business. I'm just curious, do you feel like, 266 is really going to improve benefiting patients or big business?
Yeah, so I don't ever want to put myself in the place of an entity that is not me and a letter that I didn't write, but I can sort of address it at a high level, if that's all right, and sort of how I would react to that.
Well, yeah, I'm asking
from a
you
pharma
the
perspective.
question.
Yeah, my sense of where they are coming from, and I would agree, is very much tied to this idea of locking in unlimited access to contract pharmacies, because we know that the folks that are benefiting from that are big vertically integrated PBMs, chain pharmacies, and TPAs. And so, not having read the letter, but sort of understanding the policy perspective, I would agree if that's what they're trying to say. And we know, and again, as it's been discussed a little bit, right, 340B is a program that directs dollars to providers that then provide a benefit to patients. It is not a program that directs dollars straight to patients. It is a little bit different in the grantee space because of, FQHCs have their federal grants, as we talked about. They have, the sliding scale, they have more requirements, not because of 340B, but because of their status as a grantee. Hospitals have a little fewer. Contract pharmacies have none because they don't exist in the law, right? And so it is absolutely the case that I may walk into a clinic, I'm underinsured or I'm uninsured and I'm low income, and I get a sliding scale and I'm benefiting directly from the 340B program. It is equally true that I may be uninsured. I walk into a hospital, I take my prescription to the contract pharmacy, CVS down the street, and just not picking on them, but just, the contract pharmacy down the street, and I pay the full list price of the medicine because I'm uninsured, or I pay the full list price because I'm in my deductible and I am insured, but I haven't hit the deductible yet, when the provider is getting a 57% discount. So yeah, we as an industry do have an issue with that happening, but I will acknowledge that the program as originally constructed isn't set up as a pass-through program.
You had mentioned the 57% at the beginning of your presentation. I just so we learned earlier that originally it was set for, I can't remember, 10% for generic,
10.1 for
15 generic, 23.
Right.
And then that increased if the cost of if the WAC on the drug was over the rate of inflation. So if your average discount is currently 57%, isn't that
Yeah, so
basically saying that that pharma's increases in drug prices have way outpaced inflation?
It's a couple of things that would incorporate everybody, and I've learned more about 340B than I want to, but I also will not claim to be an expert in exactly how the formula works. Frankly, it's the first time I've seen that described as exactly like the Medicaid rebates, right? But I do understand that it's a very good analogy. And so the way the program works in the Medicaid drug rebate program, and then translating over to 340B, ceiling price in 340B is not a public number. The full discount is not a public number, but thinking about it as Medicaid best price as a decent analogy. And that formula does mimic Medicaid. So that makes sense to me that that's the approach. And again, I will just reiterate that, yeah, list prices have gone up while net prices have remained relatively stable because a bigger and bigger chunk of that gap between list and net price get gobbled up by PBMs, by the 340B program, by Medicaid rebates. So list price as a marker of actual drug prices is a bit misleading.
Any other questions? Okay, so we have to get to the floor. We would really like to hear from Blue Cross Blue Shield. I think we're having a short floor today, so we're gonna come back here after floor and we'll allow Sarah to, not allow, we're inviting Sarah. We're inviting Sarah to come back then, and then we are going to finish our budget, and everybody, I hope, has put